Hello and welcome to the next instalment in our series of interviews for the Midland Science Festival. The Midland Science Festival is hosted by Midland Science, who are based here in Tullamore, County Offaly, and is supported by Science Foundation Ireland as part of the National Science Week programme. I'm Craig Slattery. I'm an assistant professor in the School of Biomolecular and Biomedical Science in University College Dublin, and this morning I'm delighted to talk with Angela Camon, who is an advanced nurse practitioner in rheumatology based here in Tullamore in the Midlands Regional Hospital. Hello, Angela. How are you?
Hi, I'm fine, thank you. How are you?
I'm good. Delighted to have you here with us today.
Thank you.
And thank you very much for your time and your expertise. So we might start off by talking a little bit about what rheumatology is and what it's all about.
Well, rheumatology, it's a branch of medicine that looks at dealing with diagnosis, treatment and management of people with rheumatic diseases, of which there are over 200.
Okay, so lots and lots of different diseases all gathered together under one umbrella term. And in terms of, I suppose, the underlying cause of those diseases, is there differences between the different groups?
Well, basically, it's autoimmune diseases that would be causing the inflammatory arthritis. So when I say there's over 200 conditions, these conditions affect joints, they can also affect organs, they can affect skin, so that's why there's a variety of conditions. With rheumatology, we concentrate on the autoimmune, the inflammatory ones.
Okay, so that word autoimmune, could you tell us what that means or what's happening for a patient in that situation?
Well, basically, when you have an autoimmune disease, it means that your immune system is attacking your body, and it can attack joints or organs or glands or skin. And it's something that's autoimmune, so it's nothing you can do anything about it.
Okay.
It can be hereditary. We do know that there are some stress factors that can trigger it, and there are some genetic factors that can trigger it. So a lot of our diagnosis is based on different blood samples in order to determine what we can come up to give a differential diagnosis.
Okay. And I suppose if we think about normal life before COVID happened, what would the average day look like from your perspective? What sort of conditions would you most frequently deal with, and what sort of patients would you see?
Okay, well, I'm working in the Midland Regional Hospital and we cover the whole area of the Midlands. So my day would comprise of having my nurse-led clinics. Most of the patients would have been seen by the consultant at some stage and diagnosed. And I was operating a treat-to-target strategy where I would take the patient who's been seen and diagnosed under my care and follow them up regularly throughout the year, and hopefully hand them back to the consultant at the end of the year for a medical review, and hopefully the patient would be in remission. So my day-to-day task would involve of having patients who have scheduled appointment to come in to see me. And for those patients, I am building up a relationship with them. And they have been diagnosed, I don't know how long they've been diagnosed, it varies every day. But for somebody who's newly diagnosed, I would give them at least a 30-minute education session discussing their disease, asking what they expect from the treatment, and trying to engage with them that we need them to engage in their treatment plan. Listen to any problems that they might have or any fears or concerns. It's all right for a consultant visit to be prescribing these drugs. And when patients go off and read up about the drugs, naturally they get scared. So when they come in to see me, that's the time to trash out any ill-gotten, what would the word you use?
Any misconceptions?
Misconceptions, yeah, that they might have had, or somebody down the road said that's rat poison, don't take it. So it's important for the patient to understand that this is their disease and this is their body. And when they can listen, when you can have a calm environment for the half hour to encourage them that, if you take these medications now, you're going to halt the progression and hopefully prevent deformities and disability in future. So when they listen to that, when they hear that, they often will engage a little bit more. So a lot of the patients, when they come, they're coming for different reasons. Some of them are for education. Some are for disease outcome measurements, which is the measurements that we score in order to ascertain if our treatment has been effective enough or not. Some of them would be coming for pre-biologic screening, which is the next step of medication that the patient may need. So there's a screening process involved, so they come for that. And some may come to start on their biologic treatments. So you may be administering the first dose with them. And for patients, giving themselves an injection is a big thing. So some will actually come to the hospital for the first injection to have given it with support.
Okay.
Other roles would be taking phone calls. We have a telephone service, and patients would have left a message if they didn't get through to me personally there, giving me their concerns. And it could be patients in the community who are facing flares which is an exacerbation of their condition. And they often are ringing for advice because they're in pain, or their joints are swollen, or they can't get out of bed to go to work, or it could be other issues that they have with infections. And these patients are always immunosuppressed with the medications that we're giving them. So we're always keen to know if they are in ill health and that they seek medical attention. And sometimes it's easier for them to ring me rather than ringing the GP practice and waiting to get an appointment. Or they may not get an appointment on the day that they need it. So they ring for current advice.
So you're almost, you're that enhanced level of care that they can contact directly when they want to, I suppose, get advice on how to taper their care or adapt to
That's true.
changes, you know.
Well, at the beginning I had a bleep and I had a phone and I had to re-look at the whole situation, because if I'm the only nurse for the whole Midlands at the time, you know, you're trying to talk to a patient and the phone and the bleep were going non-stop. So I had to limit the time that people could ring in with their queries, and I would answer those calls in between patients.
Okay.
So it's not that they could ring up and talk to me every day, because that was surmountable.
Not manageable.
No.
Yeah.
Also, people are ringing up looking for prescriptions, repeat prescriptions for the medications. And as a nurse, if I am prescribing, I have to make sure that it is safe to prescribe. So there would be a lot more questions, asking about their infection rates, asking about their attendance at hospitals, asking them have they seen any other medical people, has there any been changed in the medications, where if they're getting a prescription renewed by a doctor, it's just write it off and give it to them. Whereas a nurse, you have to make sure that it's safe to give it to the patient.
Okay.
So that takes a lot of time too.
Yeah.
And then you have the knocks on the doors.
Right.
People are in the hospital visiting some of the other clinics, and they decide to walk down, that there's a question that they want to ask. So the door is nearly always open that they can come pop down.
People will
So every day
come
is
down and
different.
engage. Yeah. And so I suppose you've covered a huge amount of information there, and from your perspective, you know, you're seeing patients at different stages of illness and disease on a daily basis. I'm just wondering, could you maybe talk us through, and I know to talk about an average person or an average experience is covering a multitude, but from a patient's point of view, how it progresses, you know, how would they initially realise that there's something wrong and they might end up?
Okay. Well, patient journey is a very volatile journey. Originally, the patient might wake up some morning and they're very stiff and sore. They might have inflamed joints, meaning that they can feel and swelling in their hands and feet, or they might have just pain on waking, and they may feel very stiff. It's what we call early morning stiffness. So their first protocol would be to the GP. A GP would assess them at the time, maybe do a set of bloods, and would give them some painkillers or maybe some non-steroidal anti-inflammatories. We've all heard of Brufen, ibuprofen, Difim, and that would be the first protocol. But when that course of treatment, maybe even a course of steroids, when that course of treatment stops after a couple of days, if the symptoms they generally will feel much better. If the symptoms reoccur within a couple of days of stopping the treatment and they go back to the GP, that's a little red flag to the GP that there's something going on here. Maybe I'll repeat what I've given them before because it did help, but maybe I'll do more bloods, more definitive bloods that might give her an idea about which services to refer the patient to.
Okay.
So by the time the patient comes to us, they've been to the GP on several occasions. They've had maybe multiple courses of steroids. They've taken the non-steroidals for a while. And each time that they stop the treatment, their joints swell up. Patients at that stage may have taken photographs of their swollen wrists, or they can't get the rings on their fingers where the fingers are swollen. They might have a knee that's suddenly swollen. So they'll start taking photographs themselves because they're researching into it. So by the time they're referred to a rheumatologist, and we all have, unfortunately, there are waiting lists. But if a GP was to do specific bloods, genetic blood tests, if they were positive, we tend to triage them a little bit more urgently than the ones that come in with no bloods. And that would give them more urgent access. Part of my role as an A&P, an advanced nurse practitioner, I'm hoping to take those people off the waiting list who have that positivity in the genetic test and see them much earlier than they would expect to be seen.
Okay.
That's all halted during COVID, but hopefully it's going to be taking place shortly. So when they get to see the consultant, they've had numerous visits to the GPs, they've been taking painkillers. Maybe painkillers have been escalated from the simple ones to the stronger ones and the opiates and the morphines. And by the time they come to consultant, then they're diagnosed. And a lot of people are overwhelmed with this diagnosis. And some people are actually delighted to have a label put on how they've been feeling. So at that consultation, they can expect to be examined from head to toe, all their joints. So I usually tell patients that, you know, they'd be expected to get into their underwear so that we can look and see and compare both sides of the body. They will have a catheter blood test taken. They probably will be sent for x-rays of their hands and feet and a chest x-ray. We would have an electronic record, so we take all their patient details from the time they were born to the time that they're sitting in front of us. So for some patients that can be exhausting to remember when I had the gallbladder out, who took my tonsils out, but we're only looking for an overview because that gives us an idea of the patient's general health. So when if the diagnosis occurs that time, we're very convinced that we're happy with a differential diagnosis, say rheumatoid arthritis or psoriatic arthritis, we would then start them on the DMARDs, which is disease-modifying anti-rheumatology drugs. And these are serious drugs. They need to be educated regarding taking them. They take up to 12 weeks to kick into the system. So the patient is told, you know, you take this medication. We give them always printed information leaflets regarding the drug. We give them printed information booklets about living with whatever condition they've been diagnosed with. And at that stage, some of them may walk into me for education, but it's not the ideal time because they're overwhelmed by all the information. They've been given so much information to the doctors for the electronic record. That's not really the time to engage and take on more information. So we usually say to the patient, go and start this medication. It's been discussed with them, the dose, where we discuss the dosing regime because we started small and escalated every month. And then after 3 months, when the drug has reached its total efficacy, then they come back to see me. And at that stage, then we can discuss any problems that they're having. They always have my phone number that if there's any side effects or if there's any adverse effects that they want to discuss, they can ring. And when they come back to see me at 12 weeks, we know then at that stage, is that drug enough to halt the progression or do we need to go further? It's when they don't turn up for that appointment that it's a problem, because some of them may have taken the tablets for a week and then stopped them, and then miss their 3-monthly appointment. I will automatically give them another appointment for another 3 months, and they mightn't turn up for that, so they don't get the consultant appointment until 11 or 12 months. So at that stage, joint erosion and damage has been done. So it's important for them to buy into the system and become self-management of their own condition and to attend those appointments. So the journey with me then, I would see them at 3 months. I might escalate, I might add in treatment. If I thought that they weren't doing very well, I might start doing the biologic workup to save them another visit to do that. So at least then at 6 months when they come back to me, if they're still not doing right, I've all the paperwork done, I've all the testing done, can start them on a biologic treatment straight away. So by the time they come back to see the consultant in 11 months, they're on the treatment and hopefully their disease outcome measurements have been reduced.
So hopefully, you know, they're on an established protocol.
Yeah.
You have a baseline from the initial assessment. They've had a period of time on whatever protocol of medicines you're recommending, and you can see is it working.
Yeah.
So I think, you know, one thing that comes across very clearly from what you're saying is that time is a big factor. So that kind of early engagement as early as possible, and then continuity and patients really taking responsibility for their own care within that, it's a big indicator for success.
That's true, yeah.
So we've talked a little bit about rheumatology and we'll come back to that and we'll talk about it in more detail in a minute. But I'd like to hear a little bit about yourself, Angela. How did you get into nursing and how did you end up working specifically in rheumatology?
Okay, well, you're going to be talking about a good few years at this stage. I started nursing, my nurse training was in the Mater Hospital in Dublin, and I trained there for the 3 years, and I staffed there, got a permanent job, and I staffed there for a further 2 years. I was there during the Stardust. I was a very junior nurse during the Stardust tragedy, unfortunately. I staffed there for 2 years, and I had an interest in cardiology and intensive care. And at that stage, back in the 80s, it was very hard. If you were permanent, if you resigned, your position wasn't refilled. So I realised I wasn't going to get any of the courses that I wanted to do. And at that stage, Australia beckoned me. And I decided then, my boyfriend at the time, we decided we were going to go to Australia for a year. So I resigned, much to my parents' disdain. And I went off to Australia for the year, and I ended up staying 5 years. So a little baby brought us back to Ireland, and I then was in the Offaly area and settled and built a house. So I came to Tullamore. And in Tullamore, I was temporary for the first year, going from area to area, which was good because then I got to see an insight into a rural hospital and to see what area I'd like to work in. And at the same time, I was writing to Dublin to get into all these postgrad courses. Eventually, I did my course and back in the Mater, and I came back and I worked in the units in Tullamore. And then life takes on, family gets bigger, and there's a lot of schooling and after schooling. And after 20 years of doing night duty and day duty, I just said I need out, and Monday to Friday. And I got a position in outpatients. So when I came to outpatients, I was getting a little bit of all the different clinics, which was great, and there was such a variety, and I didn't realise how much variety took place. We had the regional orthopaedic unit, regional ENT unit, and regional oncology, rheumatology. And I worked for a couple of months trying to find out what area did I really want to work in. And we had a visiting consultant, a rheumatologist coming from Mullingar, excuse me, and he's passed on now. And he did a clinic on a Friday. And being the new one in the block and outpatients, I got landed with the Friday clinics, but nobody told me that they went on till 8 o'clock at night. So I ended up staying in the rheumatology clinics on a Friday, which started at 1 and finished around 8 or half 8. And realised I was hearing words that I hadn't heard before in all my experience, and I didn't really understand it. In my training, I can remember people coming in chairs and gargled hands, twisted hands, and there was nothing much we can do to them. We were giving them gold injections and we were giving them steroids, but I really didn't know too much about it. And then suddenly, this was the millennium, this was the lampshade, or the light bulb. There was all these new drugs being brought out that can help these people. So when that consultant passed on, unfortunately, we got a consultant, permanent consultant, and I took it over with him that I was interested, and I went on to further my career. I did a few short courses in Ards Cross, and then went on to UCD to do the postgrad course in rheumatology, and have just completed my master's in Trinity there in the last 2 or 3 years. So it's been a world.
It's been an interesting journey.
But in that time, rheumatology has really, really developed. As I said, 20 years ago, we did what we could for the patients, and there's no cure. But we did what we could, and if it worked, very good. If it didn't, unfortunate for the patient. But now we've got such a variety of drugs, and we do know now that we can keep people working, living, continue, having babies, living their lives with a rheumatology condition because of the medications that we have.
Yeah, it's a really interesting. As a disease area, the evolution that has come in the last 20 years, as you said, there was very little you could offer in way of medication. It was about, I suppose, lifestyle modification and trying to make the burden a bit less. But now there are very powerful interventions and very powerful medicines that you can use and you can prescribe for patients. Could you maybe talk a little bit about why they're different, the newer medicines, the biologics that you talked about? Okay,
well, straight away when somebody's diagnosed, we start off with the simple drugs. Well, they're simple, but they're the DMARDs, the disease modifying, the most straightforward, and they're the ones that are out for years. So what the people might have heard was methotrexate, sulfasalazine, hydroxychloroquine, Imuran, azathioprine. Like a lot of those drugs have been out for many years. And for some patients, by taking those medications as prescribed, they did quite well. But there was a subset of people that no matter what drugs that they took, and no matter what combination of the drugs we took, that their disease still was progressing. So thankfully, scientists went off to investigate, and they started discovering these cells that they found that were involved in clumping of inflammation cells. So we've heard of tumor necrosis, we've heard of all these words. And it was where companies started looking to see, well, if we can target something that can shut down that process, maybe we can help these people with arthritis. So the first drug has been out over 25 years. It lost its patency there 2 years ago. And that was a life changer for an awful lot of patients. And that coincided with the time I was in outpatients, just beginning to learn about rheumatology. There was people coming in and this drug had just been launched and they were starting on it. And the idea was, well, we'll either give it to you, it'll either cure you or kill you. We didn't know too much about it. So that worked quite well. Some people that went on that medication, despite having years of all the other medications, they did very well. And those others didn't do a thing for them.
Didn't respond, yeah.
So then a second drug came out shortly after that. And so we now had 2. So we often gave number 1 first and switched to number 2, or gave number 2 first and switched to number 1. And we had that for about 5 years. That was going well. And since then, we've had so many are after coming on the market. And they're licensed for quite a lot of the drugs. So these drugs have been the life changer for the patients, and especially in the younger patients starting off, whose maybe grandparents had rheumatoid arthritis. When we give these biologics at an earlier age, if the DMARDs don't work, they can actually see light at the end of the tunnel, that they can actually live with their condition and not get the twisted joints that their relatives would have had in the past. So it's been a life changer. It's keeping people at work, it's keeping people young. But there's a lot of the drugs out there. And following from that now, we've got now what we call the JAK inhibitors. So they're targeting a different cellular pathway. And it's just great choice for the patients. It's great.
That's brilliant, yeah. I suppose the complication then with, you have a potentially lifelong disease, a chronic progressive disease, and we're talking about early intervention, and some people now being diagnosed quite early on in life and starting these treatments, but they still have to live their lives. And you mentioned this already, people maybe want to have children and they're also getting older. So there's sometimes a little bit of swapping around with medications and management around that.
That's true. We advocate to see the patient as early as we can when they're diagnosed, so we can get them on their treatment pathway. And that's when they come to see me for the education, especially the females. Like methotrexate is a very powerful drug, but you cannot take it if you're planning a pregnancy. Now, 20 years ago, those people would have thought, oh, I can't have children because I'm taking methotrexate. We have so many drugs out now that we can plan a pregnancy with our patients. If they have told us that they're looking to plan a family, we will give them drugs that they can take when they want to when they're planning a pregnancy. And we now have biologics that don't cross the placenta barrier, so they can safely take that for the first 6 months of their pregnancies. So we work well with the patient if they engage with us and tell us what their plans are. On the other end, then you've got the older patients, and these are people who have maybe tried and taken everything, and there's disease still advanced. But unfortunately, a lot of those older patients might be having flares of osteoarthritis, which is the degenerative arthritis that we're all guaranteed to get at some stage of our lives. And sometimes it's very hard for them to distinguish what is inflammatory and what is non-inflammatory. And it all depends on their consultation when they come to the clinics. If they just come in and talk about pain, if their consultation doesn't really ascertain where is their pain coming from, their medications are often changed. And that necessarily isn't always what the patient needs at the time, because if you keep changing biologics, from one to the other, you do run out of options at some stage, where it might be a painful degenerative pain in the hip that would be more relieved by painkillers and by patches and things. So it's trying to get the patient to distinguish when they're complaining or when they're reporting pain, whether it's degenerative pain or whether it's an inflammatory pain. That takes a lot of learning, but it can also help with their choice of medications. And when it is degenerative, then we can always, some of the hips and the knees may need replacements. They've put up a good few years. We would then refer them to orthopedics. If it is degenerative pain in the back and there's not an awful lot that can be done from a rheumatology point of view, we would refer them to our colleagues, the pain specialists, who can often do, specific injections under ultrasound guidance, under MRI guidance, and that can help the patients. But it's to distinguish what kind of pains that they're having. So certainly we're looking after the patients from at all stages of life. Remember, we're dealing with, teenagers. I personally don't deal with paediatrics now, that's dealt with in the Children's Hospital, but I deal with some of the transitioning children coming into the adult service. So they're leaving paediatrics behind and they're now becoming an adult. So you're dealing with that age group too. And they all want to travel, they all want to engage with, most of them want to go to college, they want to live their lives, and you can see where they're coming from. So to participate in their planning is great, and to be able to advise them, yes, they can go to Australia, yes, they can go kayaking. Yes, now, okay, jumping out of an airplane might be something different, but there is a certain amount of things that they can do, and you encourage them to reach their full potential. But you can always advocate that the drugs that they take, you'll guide them for each step of their lifespan. Yeah,
so really important from that is the initial diagnosis and figuring out what's going on as early as possible so you can maximise the options.
Yeah.
So we've managed to go a good distance without talking about COVID, which I'm surprised, but let's take that a journey down that street now. So across the healthcare system, we're constantly hearing of the impact COVID has had on patient assessments, waiting lists, access to treatment. Can you tell us specifically with rheumatology what the impact of COVID has been and continues to be?
Okay, COVID, when it did hit back in March of 2020, we were told on a Friday, clear out outpatients. It's becoming a COVID casualty on Monday. So everything down to the light fittings had to be taken out of rooms that were already overpacked. And we had to move, which meant that if we had to move, then that was outpatients was gone for the patients. So everything had to be cancelled for their appointments are booked months in advance. I moved 3 times into potholes, small little cabins, until I eventually got an office out in the back of the hospital. But for patients, that meant they got cancelled. Well, they were reading it on the media, they were hearing it on the media that the outpatients were all cancelled throughout all of Ireland. So for them, I'm taking these drugs. I have no appointment. My GPs aren't answering the phones, or I can't get through to the GPs. What am I going to do? I'm on these serious medications. So there was a lot of fear. There was also the fear of coming to a hospital. We all heard about the COVID numbers and the figures that were in each hospital. For the staff and for myself personally, I was terrified of coming into the hospital because COVID, this was something new. We knew we'd no outpatients, but I still needed to be there for the patients because at least they had the phone access, and that phone was utilised morning, noon and night. So patients could contact me by phone. They were terrified of COVID. They realised that they were immunosuppressed, and does that mean that they're going to pick up COVID much more than the next person? You were trying to reassure them that you can only pick up COVID when you're exposed to COVID. Just by taking these medications isn't going to cause COVID, but you have to be exposed to the virus to develop it. So the best thing you can do is stay at home and stay safe. And this is before all the cocooning business and all had been publicly known. So these patients were staying at home. They wanted to know, should they stop the medication? And we were very, very firm with that. No, because if you did stop your medication and you did have a significant flare, which mightn't happen for a few weeks, but it would happen, access to a GP was going to be impossible because they were all being watching for COVID. And therefore, you were going to have to end up coming into casualty anyway. So what did you want? We were saying you're better off taking your medications. We will guide you through it. We will increase or decrease as we think is necessary and as more information was to come to our knowledge. But for the moment, take your medication and just stay safe and don't go out. So for some patients, that was great. They were happy enough with that. Other patients then had bad flares. So we just say, I had 1 or 2 people that had swollen knees, and historically I would have brought them in. I can do an intra-articular injection where I put a needle in into a joint, take off some fluid and inject steroid and local anaesthetic. And some patients, they come in every couple of months to have that done, and it's great. So how do you tell people that are hobbling around on their feet with no crutches, trying to you can't just say, well, COVID is here, so you can't come. So some of them did have to come to casualty, and casualty were trying to streamline that there was zone A for COVID and B for non-COVID, but patients were terrified. So we did try to get those people in as what we could do. We also had patients who were getting these biologics by infusions. These were drugs that they come in to the hospital, I'd put in a cannula into their arm and give them the infusion, which can be over 3 to 4 hours, or some of them over an hour. They would be in my room for a couple of hours to be observed, and then they go home. Then they would repeat that every month. So for those patients for COVID, they needed these drugs. They were on other medications, but they needed these drugs for their arthritis. So that was probably called urgent care. They needed to be carried out. So speaking with management at the hospital, we then decided that the day hospital, which their numbers were being reduced because there wasn't the elective surgery going on. So I was able to secure beds up in the day hospital for those patients. So they would at least be able to come in, and they needed to wear masks and the hand hygiene. They came in. I would do a phone call the day before to make sure that they had no symptoms of COVID. And if everything was okay, they came into the hospital, they had their infusions, and they went out. There was no coffee shop to give them a coffee. It was unreal times, really. So then when the advent of they were making the vaccinations, all these patients are immunosuppressed. They're reading into papers, they were listening to it on the news. Immunosuppressed patients need to be done. They need to be treated urgently. So there was another clutter of phone calls morning, noon and night regarding those. And then we were tasked with doing a vaccination list for the category 4s for those who were immunosuppressed. And that meant sitting at a computer for hours on end, pulling up, like we had over 3,400 patients that come back to us in follow-up, trying to pick out those who were severely immunosuppressed with the biologics and the DMARDs, and then putting it into a template for them to go to the vaccination centres. At the same time, GPs were starting with the over 80s and were working their age group down. So that took a lot of work. And then we had the cyber attack. And the cyber attack eradicated all the lists that we had done, and a lot of our PCs we lost all our emails. So started back to square one. So at the moment, when I spoke last to you, I was last night working on another list.
Right.
And this is for the immunosuppressed again, for this enhancement of their vaccines, which will hopefully will be rolled out in the next couple of weeks. GPs now are being tasked to do the over 80s at the moment, and we're tasked to do all the immunosuppressed. So the difficulty this time with this list is we have our biologics list, which we had already done, but we also have to include the people on these medications like the methotrexate that we didn't have to include the last time because they were being met with the GPs with their age groups. So now we've put them into this list for the vaccination centres.
Groups that weren't covered in the national programme.
Yeah, so everywhere we hear in the news or in the media every day that they're working on this list, and some of the GPs have started, and all our patients then will be called to a vaccination centre. We're given their addresses, so hopefully they'll be called to the nearest one to them. So they don't need to contact us. If they attend our service, we have enrolled their names on these lists, and we'll be handing this list on to the vaccination centres, and they'll be doing the calling out. And we're encouraging the patients to go for the vaccine, because the reason for this enhancement of the vaccine, they haven't enough research out there to definitively prove it. But if patients were immunosuppressed and they took the vaccine, they mightn't have got the complete effect of that vaccine, as opposed to the next person who wasn't taking any immunomodulation. So they're hoping that by giving this enhanced vaccine, it will help.
So for the vaccine to work, you need a good response from the immune system, and all these patients, their immune system is being dampened down by the drugs anyway. So there's a chance that
they mightn't have got the full benefit.
It wasn't as powerful as it might have been.
Yeah.
So I suppose from what you've described there, a massive impact on the quality of life of patients, on their care for the last year and a half. And when on the news and in media, when we hear talk about vulnerable groups, this is one of the most vulnerable groups that are being identified for COVID. So this is the real impact of COVID on people and on their lives. And it must have created a lot of anxiety and a lot of fear for these patients.
Oh, it did. I mean, the phone calls, what would have been an ordinary phone call of 2 or 3 minutes or maybe 5 minutes, suddenly they were 20 minutes because maybe I was the only person that they were speaking to for that day. All their fears, all their concerns, down to about what happens if something happens and they're not found for a couple of days. So people really needed a helpline, and that's when they'd ring the nurse because they knew the nurse well. They knew that the nurse knew them. All you could do was support them and get them encourage them to get the family to do the shopping. And I must admit, the local GA centres and all the agencies were fantastic. There was young people willing to do their shopping. There was people turning their turf to fill the turf shed for them for the winter. There were people delivering their groceries. I mean, the community spirit really, really got together in order to help these, especially the vulnerable and the elderly out. There were some people then that there was no services, and it's hard to know whether they just didn't partake in the services or that there was particularly no service, but it's hard to imagine that there was no service anywhere because quite a lot of the areas were well covered. But these patients these clients needed sometimes just to see a person. We all heard about the postman coming up and ringing the bell, even if he had no post to deliver, and maybe dropping in the paper.
Just human contact.
It was human contact, because a lot of people had no social contact whatsoever. Down to their meals, down to cooking. They were terrified of giving credit cards and buying their groceries online. A lot of them didn't know how to work online. So it was a very difficult. I really, really felt for these patients that they were very socially disadvantaged. Yeah. I had one lady in my clinic yesterday who's 81, and she's a regular of mine, and I like to count her as a good friend. I've had looked after her for so many years, and she cocooned at home. She had a daughter living not too far, but the daughter had a family. So there was always the fear that the kids would bring it to the daughter and then the daughter would bring it to the mother. So she was cocooning at home. And mentally, it was nerve-wracking because she said she was terrified going to bed. She knew that she had family to do the shopping and drop in the groceries. But the day was so long. And in actual fact, that she deconditioned during that time because she wasn't out walking, she wasn't doing anything. But now we've got her into the gym in the AIT in Athlone, and there was some incentive there. I can't remember the name of it to hand now, but the HSE funded it. And there's a program there where they're exercising under physiotherapists there and sports medicine. And she just reported to me yesterday, she'd just come back from her class and she was feeling great. It was the interaction with other people, being able to compare and talk and contrast, and the fact that she was actually doing gentle exercises under supervision. And she was driving, I'd say about 70 miles to get to Athlone 3 times a week. And she really engaged with it because it was a lifeline for her. So hopefully that can be enhanced elsewhere. But they really did have it. They really were disadvantaged. Then when they were ringing, trying to get to a GP for other conditions, GPs were already so busy doing the vaccinations. There was swabs being needed to get in and to get access. So the patients felt very cut off.
Yeah, lots of layers added to the whole process.
Yeah, it wasn't easy on them. Yeah.
And I suppose there will be patients that continue to engage with you throughout COVID, but I'm sure as well there were patients who dropped off the radar altogether and maybe are only now coming out or re-engaging with the service.
That's true. A lot of our biologics, the injections that the patients give themselves, the prescriptions are for 6 months. So I suppose we were protected in that sense. So when they needed a new prescription, because the chemist can't hand it out without this new prescription, it's done on an electronic hub. So with COVID, they were allowed maybe elongate the prescription for 3 months, but apart from that, so patients had to engage with us. So when we were ringing the patients then, when they were looking with the prescription, we were finding that they hadn't been out of the house. There was no blood monitoring being done. And blood monitoring is so important when you're on these medications. They were telling us that they couldn't get into the practice to have the bloods taken. They didn't want to come to a hospital to have the bloods taken, so they were in a catch-22 situation. Outpatients didn't open for a while, and in some centres it hasn't still opened. We were very lucky that a consultant has an office in outpatients, so he got carpentry to open the door and he was able to see patients through that door of the general concourse rather than coming into outpatients. So he started seeing patients as early back as May,
right,
which was really good. But I couldn't bring people. I'm out in a prefab at the back, and that's not designed for seeing patients. But so a lot of it was phone contact and video contacting and virtual attendance. It was great then patients were taking photographs of swollen joints to prove to me that things were flaring. And WhatsApp was a great send, that they were able to WhatsApp it into me for me to see and then to make a clinical judgment and decide about what prescription that they would need and then to be able to send it out. So patients did do a lot in order to engage with the service. There were others that didn't. And then straight away, there was problems. Some people had stopped the medication and came back in flares. They had to be admitted. And some people just looked for steroids after steroids, which we don't like giving out long term. So it was difficult for some.
So you mentioned at the very start, you would deal with up to 200 different sorts of disorders or illnesses under the umbrella of rheumatology, and obviously some of them are quite common and people will have heard of them, but I'm sure there are a few quite rare ones as well that people mightn't have heard of. Yeah,
that's true. Rheumatoid arthritis is, there's 1 in 5 will have some kind of an inflammatory arthritis of some description. Rheumatoid arthritis, there's over, I think there's over 50,000 people in Ireland at the moment as per registry. It can affect all ages of life. There's children in Crumlin Hospital as we speak today who are on all these wonderful drugs, and parents are injecting them at the age of 3, and they're going to have a lifelong of these medications to halt the progression of their disease. We have them, we have the 80s and 90-year-olds in our age group that we're looking after them in their latter years. So rheumatoid is a very...
It's the most prevalent.
Most prevalent, yeah. We have psoriatic arthritis, and it's from people who have psoriasis at some stage in their life, and then developed joint pain, and we label then that as psoriatic arthritis. And we've got different genetic blood tests that we can do to determine which is which. We've also got a condition called ankylosing spondylitis, and it's a condition that affects males more than females. For once, males are getting something.
Right.
Where the others are more common in females. But males, it's more common in males, and it usually affects them in their 20s and 30s.
Okay. And what sort of symptoms would you?
A lot of them will come in. Back pain would be their main issue, and it's back pain that's not mechanical, so it hasn't been caused by any trauma. So they can suddenly, find difficulty finding a comfortable position in bed at night, wake up very, very stiff and unable to move. They find that they have a back pain, that they can't say that they overworked in the gym or that they lifted something heavy. The back pain kind of eases off as they move, but then gets bad when they sit. And they reach out for the Panadol to relieve this pain, and then they end up taking maybe some Nurofen, and they can't explain why they have this pain. So a lot of them will go to chiropractors or physiotherapy just to see can they get it massaged out. And eventually they will go to a GP when it's long-standing. So anything that's greater than 6 weeks and it hasn't had any, there's been no clinical factors to cause the pain, we would always say it's a little bit of a red alert to know why somebody young is having this pain. X-rays don't always show it at the very beginning. We have a genetic blood test that we can do, but not everybody who has it would have this condition. And people who haven't got it could still have the condition without having the genetic. So it's a hit and miss in that sense. But MRI is the way to pick that up. And even at that, we have some that will show it'll be what we call it is visible on the X-rays and the MRIs, and others that it isn't. So basically, they've got this pain in their back. If it's allowed to progress, the vertebrae, which are the bones in your back, can fuse together, and then it starts limiting your movement and your freedom, and eventually they end up stiffening. And you might see some patients who are with their head bent forward, and they lose that mobility. So that can impact on their driving abilities. And young people are all driving nowadays. So if something like that and their neck has been bent, we can't undo the damage that has occurred by the time it gets to us, but we can hopefully prevent that damage if there are early diagnosis. These patients can do very, very well, and these patients, we don't usually start them on the DMARD drugs that we do for other conditions, because we know from research that they don't work. Okay. So we put them straight onto a biologic. So at the beginning, we're not curtailed in the people that we can prescribe a biologic to, but we offset the cost of the biologic with keeping somebody at work, working, and less disability.
Normal life for longer.
Yeah.
So I suppose two things in there, really interesting, that 6 weeks. If you've had a problem, it probably goes across all areas of health. If you've had a problem and you can't identify a cause and it's persistent, you need to go and see somebody about it.
Yeah.
And of course, men are notorious for kicking things down the road and not going to the GP.
Well, sometimes when they go to a GP, it could be back pain, and maybe the back pain is mechanical, maybe they've done something. But, all these arthritis can affect other areas. We've an eye condition called uveitis, and that can be very, very painful for a patient. They have a red hot eye that needs urgent attention, so we would refer them up to the Eye and Ear Hospital in Dublin. And that would have some patients who have that condition or who present to the Eye and Ear have the same genetic blood test positive that somebody with ankylosing spondylitis may have as well. Okay. So it's very important that if you have a red hot eye, that it's a flag to the GP, or somebody to say, well, if you have this, maybe I'll check you for this, and maybe we'll work it out. We have people with bowel disease, Crohn's disease, ulcerative colitis, and sometimes their genetic makeup is something similar to the genetic makeup that we have with our patients. And interestingly, the biologics that we use, the treatments we use, work for these conditions as well.
They have multiple benefits.
So when you have a drug like a biologic, it's licensed for rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, uveitis, so that they get the licensing for a lot of the conditions.
But they're all rooted in autoimmune.
Yeah.
So you mentioned with ankylosing spondylitis that you have this kind of characteristic posture change, and you get hunched, and you see that with things like osteoporosis as well. Is it similar, or?
Yeah, well, there are different conditions. With the ankylosing spondylitis, it's where the spine fuses together. But when it happens up in the neck, the neck can often be brought forward. So that's why it gives you that posture change. With osteoporosis, it's different. That's another condition that we look after as well. And it's all to do with bone health. And osteoporosis is degeneration of the bone matrix. So people start losing their bone density. Now, we're all guaranteed, as we pay taxes, to lose our bone density at some stage. But if you consider, for young people out there, that when you're taking milk and you're eating your dairy-free, your dairy products and your calcium products as a child, you build up. It's like savings in a bank. You're building it up, and then when you reach your mid-20s, that building up stops. And then, especially with females, as you progress through the hormonal changes, and when you reach the menopause, you start losing automatically, because you've dropped your estrogen. You stop losing your bone density. So if you haven't got a bank built up, and you start losing it, the more you have to lose, the better for yourself. But if you don't build up a bank, like what children now are taking milk with their dinners and eating the calcium, they're all on sodas, and they're all, we see it in the clinic, they're just not taking the calcium intake. So if they don't build it up until their mid-20s, they've got less to lose as they get older. With all our rheumatology conditions, of which there are 200, a lot of those treatments at the beginning when they're flares will be steroids. And we know that steroids are, we don't like to give them for long term, because they don't help with the bones. So we would give calcium supplements when we're giving the steroids, and we try to get people off steroids as much as possible in order to preserve the bone. So with osteoporosis then, there's degeneration of the bone matrix, and people the bone starts, I should have brought a little sample, but the bone starts chiseling away, and eventually they lose vertebral height. They can fracture easily when they have a simple fall, where normally you shouldn't fracture a bone if you've got proper bone density. And the long-term complications of the osteoporosis is phenomenal. I mean, they come in with fractured hips, and unfortunately the statistics are saying that only 1 in 5 will get back out to normal living. A lot of them will be ended up in some kind of form of nursing homes.
Right.
So with osteoporosis, we'd say you need to keep your exercise. You need bone building exercises. You need to keep weight. If you don't use it, you're going to lose it. So we're encouraging patients, even if they're not out and about, to just do gentle exercises. Even just walking up 2 steps of a stairs and down again. That's weight taking, and it builds up the muscle power that may protect them.
Yeah. I think that, I was just going to ask you about that, because, when we think of osteoporosis, we're concentrating on the bones and even joint care. We tend to think about the bony structures, but the muscles and the supporting,
they all need to be,
architecture around that and maintaining that is just as important.
Oh, it is, of course, because if you don't use your muscle tone gets slack, and then any kind of a simple incident can cause more injury because it's been lack of tone.
Yeah.
So for patients who are elderly, we just say, even if they haven't got a stairs, if they just walk up a step or two, doing different things like that. Trips and falls would be a big thing. That's a big thing in our education sessions. If they've got osteoporosis, I won't say they're all elderly, because we've got young people with osteoporosis, mainly the people who've had eating disorders, and we've got young women who maybe have had to have a hysterectomy. They go into an early menopause and they could develop osteoporosis. So it can go through, of course, all stages, maybe not children, but all stages. So for osteoporosis, the risks are, if you're looking after a mother or father or granny or granddad, to make sure that there's lighting in the house, make sure there's no mats with curled up edges, make sure that their glasses are working, that that the glasses are changed regularly, make sure if they get up to go to the loo in the middle of the night that they turn on a light, that they're not struggling around in the dark, because a simple fall to somebody with osteoporosis could mean end of independent living. Yeah. So the trips and fall, we have trips and fall clinics, we have physios that will teach the trips and falls exercises, and we have patients who come into the hospital for trips and falls exercise program for a couple of weeks. They're all the things we can do to hopefully prevent further fractures. But unfortunately, we do get patients into casualty who come in with back pain, who have x-rays, and they say that they've a couple of fractures in the back. They're admitted for pain relief, and then we go up to see them. And so we will give them some treatment. There again, we have more treatment for osteoporosis, and we replace them with teriparatide hormone. And these are injections that the patient will take for a period of 2 years, and then we switch them to something else for their bone protection. So it's a big umbrella. Some hospitals have fracture liaison nurses who will look after osteoporosis. Some smaller hospitals in the Midlands, we don't. So we're just trying to capture everything that we can. But we encourage all our young people to eat and drink the dairy, the calcium. We give calcium information leaflets to the patients. Even a tin of salmon, if you're not into big fish eating, crunch the bone, you know the way the vertebrae is in the salmon. When you get it, I always pick that out and give it to the dog. Now I crunch it up with a fork because that's the highest concentration of calcium is in that bone. Yeah. So calcium intake is very, very important. Then you've got the other conditions which are too numerous now. You've got sclerodermas, you've got the lupus, and they're all connective tissue diseases where they involve organs and skin. And it's all highly specialised rheumatologists that will look after those kind of conditions. And they're all on those kind of particular drugs in different doses in order to halt the progression.
So with any area of healthcare, you always find myths and misconceptions among patients and among the general public. Are there any around rheumatology and joint care that particularly annoy you and you'd like to shoot down here and now?
Okay, well, a lot of patients come and you've educated them and you're supporting them in their journey. And after an education session, they will say, and after 3 months, am I finished? So they have this idea that it's a quick fix. There is no cure for a lot of these conditions, but we can safely manage them and prevent them from getting worse. But this myth is out there. If you come to see a rheumatologist, you get diagnosed, you get a label, you get medications, and after that you're all right.
You're done.
You're done. It doesn't work like that. You're going to be in some form. We won't say you're going to be on this particular drug, but you're going to be in some form of medication for the remainder of your life. And that's why you're going to be on our follow-up sheet for the remainder of your life. So there's not a myth that you can come and have a quick fix and that it all is going to be sorted out with a couple of injections. Doesn't work.
Yeah.
There's also people coming in and they'll say, well, if I eat oranges, nurses, did that cause me to have my flare? Or if I had eaten tomatoes? We don't go down the road of any food allergies or food inconsistencies. We would always encourage the patient, if you feel something is flaring you or does not agree with you, you stop it. Reintroduce it in 6 to 8 weeks. If the same symptoms occur again, then stop it permanently. But we're not going to be going down the road of saying, well, you can have 2 tomatoes, but you can have only 1 grapefruit and whatever. We will always advise when there's medications that are contraindicated to take with the likes of grapefruit or cheese or something like that. But that would be always with your medication education sessions. But you can eat whatever you want, whenever you want. Alcohol is another thing though.
Right.
We will always just encourage you to a moderate intake of alcohol because a lot of our drugs are safe to take if you're only a moderate drinker. But if you're taking excessive drinking and binge drinking, that can interfere with your liver function. And when your general practitioner sees an abnormality in your liver function when they do your bloods, they panic and they say, stop the methotrexate straight away, when actually it was the alcohol and the hen night and whatever that you were at that caused that. So alcohol in moderation. Smoking, it can be a stressful factor. Smoking itself won't cause any of the inflammatory conditions, but it doesn't help. And we would encourage all of our patients to consider giving up the cigarettes because it is a pollutant and it is an allergen, and we won't say that it caused any of the conditions, but it's certainly not helping.
Not helping with them, yeah.
And especially with our conditions, if you're immunosuppressed, you're going to be exposed to the flu and the other viruses that are out there. So, when you're smoking, you're going to have chest infection, you're going to need antibiotics. And when you're taking biologics, you can't have beyond antibiotics at the same time. So therefore, you're going to stop these medications and you might flare. So it's a whole vicious circle. So we would talk about, the cigarettes and the alcohol to be...
There's an awful lot of juggling goes on, and
yeah, and
the less things you have to juggle, the better.
And each time a patient comes, it's different.
Yeah.
Today, it might be something that's an issue, and then 3 months later, it's something else. So it's whatever's important to the patient is what we need to discuss and get through with them. But the myths, Johnny down the road told me that drug is rat poison. We hear so many of those stories.
Yeah.
Wish to God Johnny down the road would keep his mouths. Because, we're not going to give drugs to patients that we don't think that will help them. We do go through the drug with them so that they understand exactly what they're taking. And really, do you take, Johnny or Facebook or anybody else's opinion on the drugs rather than the healthcare professionals who've discussed the drug with you? So if you have any pertinent questions, you come back to a healthcare professional, not Johnny down the road.
That's good advice for life. So maybe just to wrap up, Angela, and we've done these interviews over the last year, and I always ask the question, you're deeply embedded in your own particular area in rheumatology care, and if there was one thing that you could introduce or one thing you could click your fingers to change or have more of or have less of, to make patient care better, what would you pick?
Nurse empowerment. I'd like to think that there's going to be more rheumatology nurses to take over from us, to learn from us now, that when we're willing to teach and when they're willing to learn, so that we would be replaced by empathic, powerful nurses. I think a lot of what goes on in healthcare is driven from the top down, and I firmly believe that in this advent of advanced nurse practitioners, we're now a voice of our own. And we did have a meeting last night, and actually something like that did come up, that we need to voice what we can do. We are a well-respected group of people, and we need to voice what we need to do for the patients, more so than being told what we can do. With more nurses, we have power, and the power would make more patient-centred care.
So I want to say a big thank you to Angela for sharing all of her expertise and her experience with us. I've learned a lot, and hopefully I'll know what to watch out for as I'm getting older myself, and try and get as much mileage out of my clock as I can. I want to say thank you to you for joining us for this interview, and I hope you'll join us again soon.